Good evening, distinguished colleagues. It's 9 p.m. already, although the attendance is still very low. Dr. Bello.
Yes.
Do you think we should start? Or
let's wait for 5 more minutes.
Okay, let's wait for 5 more minutes.
Yes, if you have up to let's start by 9:05.
Okay, sir. Thank you. Okay. Good evening once again. You are all welcome to our first clinical presentation for the year 2022. I want to welcome everybody to this first presentation. My name is Dr. Timipri Okerogene Agogo. I'll be your moderator for tonight's clinical presentation. So I'll be welcoming most of our CPAN, VIPs, and also major stakeholders that will be present here tonight. Also the fellows of PSN, and also fellows of the West African Postgraduate College of Pharmacists. We are also going to be welcoming all CPAN, all the members of CPAN that are in this thing, diaspora, all state coordinators present here. In fact, today we are going to be taking roll call, but because of time, we want to tell us that if you know that you are a state representative, please just kindly drop your name and your state in the chat box so that I can see it and also acknowledge the state instead of calling that, because that will take us time to take all the roll calls from all the 36 states. At this point, we want to start with an opening prayer. So please, Pharmacist Musa Mohammed, please can you help us with an opening prayer, a brief opening prayer? Thank you. Unmute yourself and talk. Unmute yourself, please.
Hello?
Yes,
Good
can hear
evening.
you.
Good evening, my senior colleagues.
Good evening.
As we are gathered here today for a clinical meeting, I pray the Almighty Allah to guide us and put us through, give us knowledge and understanding. I pray may God protect and guide us through what you are about to listen today. And may He continue to protect and guide our family. May He grow the profession. May He make the profession grow higher and higher.
Amen.
اللهم صل على سيدنا محمد وعلى ال محمد كما صليت على ابراهيم وعلى ال ابراهيم انك حميد مجيد.
Amen. Thank you very much, Pharmacist Musa Mohammed. Really appreciate that prayer. At this point, I'm going to be recognizing our national secretary. She's here, Dr. Buki Motiha, please, you are welcome. Also the vice chairman, she's here too, Dr. Maureen Uwafo. You are highly recognized. So as they come in, I'll be recognizing them. Meanwhile, our presenter for tonight is set already. She is Pharmacist Mrs. Abubakar Zainab Galadima. We have already read her profile. She's a researcher and a trainee. She had other additional qualification from other university, but today she'll be talking to us on the role of a pharmacist in the management of sickle cell disease complication. It's actually a case report from the University of Abuja Teaching Hospital. So please, ma, you can start now.
Thank you very much, Pharmacist Tini. Good evening, my distinguished colleagues. As introduced, I'm Pharmacist Abubakar Zainab Galadima, a chief pharmacist from the University of Abuja Teaching Hospital, and I'm representing the FCTC in today's presentation. This evening, we'll be looking at the role of pharmacists in the management of sickle cell disease complication, a case report. This is my outline. I have abbreviations, abstract, introduction, case report, pharmaceutical care plan, conclusion and recommendation, consent form, perspective of caretaker on treatment, and references. These are the abbreviations. I wouldn't want to take each one of them so that it won't waste time. We described a case of sickle cell disease complication where the patient presented with features of acute painful episode and a hyperhemolytic crisis secondary to sepsis with suspected iron overload that later degenerated to meningitis and CVA. The diagnosis was confirmed with MRI, abdominal USS, and blood work. The patient was treated with antibiotics, antihypertensive, and nutritional rehabilitation. In this case, we carried out from school care intervention using the SOAP approach, which is a subjective, objective assessment and plan. And it resulted to a good clinical, economic, and excellent humanistic outcomes. It's a known fact that there's a drastic reduction in the quality of life. And also there's a decrease in life expectancy with sickle cell disease patient. So it is therefore imperative for this patient to be well managed and adequately treated. And this can be achieved only with a multidisciplinary team approach. Within this team, we have the pharmacist, and the pharmacists have the opportunity of ensuring optimal medication therapy for each individual patient. Let's refresh our memory a little about sickle cell disease. We all know that sickle cell disease is a hemoglobin S disease and is a lifelong disease. It's also more prevalent in Africa. So by way of definition, is a group of inherited red blood cell disorder that has been caused by abnormal hemoglobin, which results in acute and chronic complications. How does this occur? It occurs when there's homozygosity of the beta S globin gene, which now results to the replacement of the hydrophilic glutamic acid with hydrophobic valine residue at the cis position. This results to a mutated hemoglobin that is a tetramer, and this occurs in the red blood cell of a sickle cell patient. This abnormal hemoglobin polymerizes, and when it polymerizes, it causes sickling of the red blood cell, which leads to vaso-occlusion, changes in blood viscosity, hemolysis, endothelial dysfunction, and inflammation. And this presents as complications. And these complications could be acute or chronic. The acute complications include vaso-occlusive crisis, acute chest syndrome, sepsis, splenic sequestration, stroke, dactylitis, or priapism, while the chronic complications include poor growth, renal disease, retinopathy, osteonecrosis, functional asplenia, cholelithiasis, learning and cognitive difficulties, silent cerebral infarct, chronic lung disease, pulmonary hypertension, and congestive heart failure. The goal of therapy in sickle cell disease is to alleviate pain, to prevent complication, and to reduce hospital visits. So it's really very important to educate patient and patient families on how to palpate the spleen. The advantage of doing this is to have early detection of the when there's splenomegaly, you can early detect it. Then prophylactic penicillin, it has been advocated for use in order to prevent any form of pneumococcal infection. And once a child is being diagnosed to have SCD, it is advised that penicillin should be commenced and immediately. And if it's not commenced, maybe at the age of 2 months, you can start giving penicillin. And this can continue to a minimum age of 5 years. Routine immunization is also encouraged, includes with pneumococcal vaccination. Transcranial Doppler helps in identifying, actually very important, because it helps to identify those patients that are at risk of coming down with stroke. Hematopoietic stem cell transplant. Currently, this is the only cure of sickle cell disease, but it has some setback. One of the setbacks is that there is lack of suitable bone marrow donors, and also the need to identify patients that have risk to benefit ratio. So because of this, Drug therapy is known to be the primary mode of management of sickle cell disease. And one of these drugs is hydroxyurea. Hydroxyurea is known to prevent complication of sickle cell disease because it increases the total fetal hemoglobin, thereby reducing the adhesion of the sickling cells to the endothelia, and also it increases polymerization time. Red blood cell transfusion is actually encouraged, is effective, and it has proven to be good, to be a good choice of treatment in preventing some complication of sickle cell disease. And this could be simple or exchange transfusion. It also reduces the abnormal hemoglobin. It reduces the percentage of abnormal hemoglobin. It prevents complication of sickle cell disease. It treats severe complication of sickle cell disease, and it lowers the risk of stroke in infants and children if it's done correctly. But if it's not done correctly, it causes what we know as iron overload. And this is a great concern because sickle cell disease patients cannot hyperabsorb iron. And this affects the distribution of iron storage in the liver. And this will now cause damages to the organs, which could be lethal. And the symptoms of this iron overload include nausea, abdominal pain, vomiting, and seizures. Our case proper. A 9-year-old known sickle cell anemic boy, OS, was referred from Kwali General Hospital, FCT, to VATH Gogolada with the features of acute painful episode and a hyperhemolytic crisis secondary to the sepsis with suspected iron overload. OS condition later degenerated to meningitis and CVA. He had turbulent period of seizures, altered state of consciousness, electrolyte imbalances, and renal injury. He complained of abdominal pain, vomiting, yellowish discoloration of the eyes, fever, and headache. He was admitted for 6 days at the referral hospital. He was transfused with a pint of blood. He had numerous admissions. The last admission was 6 days ago. No surgeries in the past. There was daily supplementation for 1 year. He was placed on ceftriaxone, artesunate, paracetamol with no improvement. Immunization history was adequate for his age. The patient resides with family in 3-bedroom with well-netted windows and doors. The patient is the fourth of 7 children. 3 died, and the cause of death was unknown. The mother is 38 years old, businesswoman with a genotype of AS. The father, 42 years old, a civil servant. Precisely, he's a policeman in Kwali here. And the genotype is AS. Medication history, no history of allergy to any drugs or food. He was placed on ceftriaxone, artesunate, and paracetamol. He received a pint of blood, and there was an iron supplement for a year. On physical examination, he was acute ill-looking in painful distress and was febrile with a temperature of 37.7 degrees. He was pale, obvious sickle cell habitus, and he weighed 26 kg with a height of 127 centimeters. The digestive system showed hepatomegaly. The respiratory system, there was respiratory distress, nasal flaring, and oxygen saturation was at 84%. The respiratory rate was 30 count per minute. There was tachypnea. The CVS, the pulse volume was full and regular. The pulse rate was 108 beats per minute. Blood pressure was 113, 65 millimeter mercury. Actually, when diagnosing pediatric hypertension, there are some parameters that are required: the age, the height, and the blood pressure, so that you can, there's a chart, the WHO chart, or you can customize your chart. So based on what we did, what we used, the normal range for this chart at 9 years old, it's 109/72. The CNS, there was confusion, seizure, and severe headache. There was renal angle tenderness. This is suggestive of cystitis or urethritis, inflammation of the bladder or inflammation of the urethra. No hematological symptoms, no urinary symptoms. The assessment, it was assessed that there's a sickle cell anemia with acute bacterial meningitis, renal impairment, and a probable case of hemochromatosis, and it was kept in view silent stroke. The laboratory investigations EU creatinine was done. The sodium was normal, potassium normal, chloride was low, bicarbonate was low, urea was high, creatinine was also high. Full blood count on day of admission was 37%. When repeated on day 3, it dropped to 21%. The ESR was raised to 80 millimeter per hour, which is also suggestive of an inflammation or bacterial infection. The white blood cell was 9.2 nano per liter. Lymphocyte was low, 14%. Neutrophils were high, 86%. The platelet was also low, 93 nano per liter. There was a blood film. The blood film was stained and it showed toxic granulation, which is also suggestive of inflammation and bacterial infection. Urine MCS, no growth. No blood culture, no growth. Urinalysis was done. There was no blood in the urine, no protein in the urine. MP showed was positive. The liver function test was done, and only the aspartate amino transaminase was high. An iron study was conducted, and it revealed there's anemia of chronic disease. Serum iron was low, 2.1. 350.7. The total iron binding capacity is low. Random blood sugar was 10.9 millimoles. CSF analysis was also done, and the CSF glucose was 35%. The normal range is between 60 to 80%. And usually when there's an infection, anything less than 40% is suggestive of bacterial infection. The CSF protein was normal. CSF gram stain and MCS, no bacterial growth. An abdominal USS was conducted, and it showed that there's renal parenchymal disease, which most likely could be glomerulonephritis. A throat swab was done, and the MCS yielded strep pneumonia, which is sensitive to clindamycin, cotrimoxazole, and erythromycin. Day 3, there was a brain CT scan, and the result was inconclusive. So MRI was requested, but due to financial constraint, it was not done. The blood pressure increased from 116 to 124 over 80 millimeter mercury, which is stage 2. Day 5, the EU creatinine was repeated, and there was electrolyte imbalances. The calcium and magnesium were low. The MRI was eventually done, and it revealed right parietal microinfarct. An MCS of the catheter tip was done, and it yielded Klebsiella species, which was sensitive to levofloxacin. Drug therapy. In day 1, intranasal oxygen was given at 2 liters per minute, ceftriaxone 75 milligram per kg in 2 divided doses, gentamicin 2.5 milligram per kg per dose. Coartem was given. 5% dextrosaline was also given at 120% maintenance. Nothing per oral was instituted. Pentazocine was given at 30 milligram when required. Ketorolac 30 milligram 8 hourly. Diazepam 10 milligram 6 hourly. Phenobarbital 15 to 20 milligram per kg. Day 3, the antibiotic was changed to meropenem and also placed on low dose amlodipine at 0.05 milligram per kg per dose. If you calculate based on the 26 kg, the weight of the child, you get 1.3 milligram. Regards lactate, day 6 or 5 milligrams of hourly. Calcium gluconate at 0.3 ml per kg dose of 10% sodium.
Wow.
She's having challenge with her network.
Network, yes.
She's having challenge with her network. She's back. She's coming back. She's back. Mrs. Zainab.
Sorry about that. Sorry, please. Sorry.
Welcome back.
Yeah, thank you very much. JC oral carbamazepine 200 milligram per oral was given. Amlodipine was increased to 2.5 12 hourly. IV calcium gluconate 0.3 ml per kg per dose of 10% solution potassium chloride. IV magnesium sulfate at 25 to 50 milligram per kg, 4 to 6 hours for 3 to 4 doses when required. Artesunate was given at 2.4 milligrams stat, then at 12 hours, 24 hours. Day 10, hydralazine at 1.5 milligrams per kg daily for 24 hours. Amlodipine was discontinued. ACE inhibitors, enalapril was given at 2.5 milligrams. Phenobarbital was changed to phenytoin. Oral calcium lactate was given 200 milligrams daily. Slow-K at 20 to 40 milli equivalent per hour. Serum kefabol was given once daily, 5 ml 3 times daily. Sorry, is giving 5 ml 3 times daily, not once daily, please. Reload was also given. Our pharmaceutical care plan constitute, we use the SOAP approach, which is subjective, objective assessment and plan. And our goal of assessment was to conduct drug use evaluation to gauge the appropriateness of drug use and the achievement of desired therapeutic outcomes. Our problem list include the subjective data, which was yellowish discoloration of the eyes, abdominal pain, vomiting, fever, and seizures. Objective data, we have elevated BP of 124 over 80 millimeter mercury. Calcium was low, 1.99. Magnesium was 0.36. The MRI showed right parietal microinfarct. MCL showed Klebsiella species and also pneumococcal pneumonia species. Serum iron was low, 2.1. PCV was 21%. Bicarbonate was 16. Urea was high, 18. Creatinine was 254. Chloride was also low. So we identified the following drug therapy problems. Number one, unnecessary drug, hydralazine, and iron. Wrong drugs, ceftriaxone, gentamicin, and meropenem. Dose too high, enalapril at 2.5 milligram. Adverse drug reaction, amlodipine. Drug interaction, magnesium sulfate, and amlodipine. These were the resolution of the drug therapy problems and were recommended to the doctors. Meropenem has empirical indication in the treatment of bacterial meningitis, yes. But meropenem is also known to cause seizures, and this patient had continuous seizures. So we recommended that cefotaxime or ceftazidime should be used because it is as effective as meropenem in the management of bacterial meningitis. The two MCS results yielded strep pneumonia and Klebsiella species, which were sensitive to cotrimoxazole, clindamycin, erythromycin, and levofloxacin, respectively. But this was not used, it wasn't considered. Hydralazine is said to be used with caution in pulmonary hypertension because of its tendency of causing severe hypotension. And it's also significantly metabolized in the liver by acetylation. And this patient was noted to have hepatomegaly. So hydralazine is also not compatible with dextrose ringers, dextrose-saline combination. So we suggested that labetalol should be used because it will reduce the blood pressure and also increase the efficiency of treatment because it have an interaction with diazepam. It increases the effect of diazepam by decreasing its metabolism. And this will be beneficial to the patient since the patient is already having seizures. Iron supplementation is contraindicated in sickle cell disease. If you remember in my introduction, I made mention that sickle cell disease patients cannot absorb iron, and this affects the distribution of iron storage in the liver, and it's lethal. It causes end organ damage. So this is contraindicated. Amlodipine appears to be an effective treatment for hypertension in children. This particular patient, the calcium serum was low, and amlodipine is found to reduce serum calcium level. And it does this in two ways, directly or indirectly. Directly, how it does is that it inhibits the function, the osteoclast function activity in the bone, the osteoclast activity function in the bone. And indirectly, it suppresses the parathyroid hormone found in the bone, and thereby further inhibiting osteoclast function. And so it will reduce the serum calcium serum concentration. And this child already has low calcium serum, so it's contraindicated. Like this is contraindicated. Amlodipine interacts with magnesium, causing hypotension. We all know that amlodipine is a calcium channel blocker, and it does this by preventing calcium from entering into the cells, thereby causing a vasodilation, decreasing total peripheral resistance, and thereby reducing blood pressure. Magnesium as well have this mechanism. It also prevents calcium from entering into the cell, and also reduces blood pressure by decreasing total peripheral resistance. So taking this together will cause hypotension. We still suggest labetalol to be used alongside with ACE inhibitors like enalapril in order to protect the kidneys. When using enalapril, it's advised that the initial dose should be given at 0.08 milligram per kg per day. And subsequently, based on the patient response, you can either increase or you leave it at that level. This child weighs 26 kg, and if you calculate this, you will see you will get 2 milligram of enalapril. That's based on this standard, as in based on this guideline. But this particular patient was placed on enalapril at 2.5 milligram, which the dose is high, because for children, its calculation of doses is based on weight. Ceftriaxone and gentamicin was not supposed to be initiated in the first place. Since the patient prior to admission was on it and there was no significant improvement, even though on coming to VACH, they used branded ceftriaxone, busulfan, and gentalin, but still there was no significant improvement. The dosage and frequency of carbamazepine, phenobarbital, omeprazole, and Gaspor were not indicated. We educated the patient on foods that are rich in folic acid and vitamins, especially fruit and vegetables. We also encourage adequate hydration at 2 liters per day for that particular age, that's the requirement. And we also emphasize on the importance of timing and adhering to medications to prevent drug resistance. We encourage moderate physical activity to improve physical fitness. We encourage intake of folic acid, prophylaxis, and also encourage prophylaxis against infections like malaria by taking Proguanil. We educated the caregiver. We taught them how to tip the spleen. The advantage for this is that it will help you to detect splenomegaly early. And how this is done is that you ask the patient to lie down supine. Then you ask the patient to take a deep breath in and out, and you place your fingertips at the left side of the abdominal wall of the patient. As the patient is taking, breathing in and out, if the spleen is enlarged, you feel the tip coming towards you. And it's advisable that you don't go looking for the enlarged spleen. You allow the spleen to come to you, because if you go looking for it, it will give you a wrong information. Wrong idea. We also counseled on the benefit of early diagnosis of crisis. We encourage condition and also activities that requires high oxygen activities. We like try to discourage them, like hiking, trekking, or strenuous exercises. We encourage regular medical care visits for 3 to 12 months. The caregivers were reassured, and we provided information to the healthcare providers whenever it's required. We also assisted in dose calculation, because dosing error is the most common type of medication error. The prognosis was good. It was improving. The complications were also resolving, and the patient was discharged. The indicators for monitoring include PCV, EU creatinine every 3 months. And the patient was discharged with the following medication: reload once daily, syrup encefalor 10 ml daily, tab enalapril 2.5 milligram daily. Oral calcium was discontinued. Slow K and phenytoin were also discontinued, and the child was placed on levofloxacin 500 milligram daily for 10 days. Our counseling point at discharge: we encourage adherence to treatment regimen and routine drugs. We also encourage, re-emphasize, because we have taught them while they were on admission, so we re-emphasize adequate hydration, 2 liters daily. We also re-emphasize avoiding getting too cold and too hot, avoid places or situations that cause exposure to high altitude, we avoid situations that increase oxygen demand, just as I said, trekking, hiking, and also strenuous exercises. We also re-emphasized avoiding taking iron supplement, and we encourage general hygiene, especially hygiene, and also regular hospital checkups. Antibiotic prescription should ideally comprise of the following phases: perception of need, is the drug necessary, choice of antibiotic, which is the most appropriate antibiotic, choice of regimen, what dose, what route of administration, frequency and duration are needed. Monitoring efficacy: is the antibiotic effective? Any antibiotic you take and you do not get any response after 3 days is not effective. But in this case, meropenem was empirically used since the patient did not respond to ceftriaxone and gentamicin. And due gentamicin, so ideally, just as we recommended to the doctors, they would have used cefotaxime or ceftazidime. Due to so many medications, there's a possibility of drug-drug interaction or drug-food interactions. And because of poor or no therapeutic drug monitoring system in place, we could not assess the pharmacokinetic parameters. It was also observed that the omeprazole and Gascol dosages were not indicated, and this shows default in the prescription pattern of the doctors. In our conclusion and recommendation, VOC, vaso-occlusive crisis, and infections are major complications of sickle cell disease. Irrational and overuse of antibiotics is therefore a great concern. Pharmacists should champion antibiotic stewardship. Pharmacists need to educate patients and caretakers on how to palpate the spleen at the onset of symptoms, since timely intervention helps reduce complication and prolong life. Pharmacists should provide timely and essential drug information and assist in calculation of doses of drugs for different dosage forms. Emergency drugs used in sickle cell disease should always be made available. Regular medical care, 3 to 12 months, depending on age and severity, should be highly encouraged. This is the consent form signed by the father of the patient. In the words of the father, he said his perspective about our treatment and our involvement. He said there is an excellent satisfaction with the pharmacist due to the availability of drugs and attention. Also, there's promptness of the pharmacist in sourcing drugs. Why he said this was because when they came, there was need for desferoxamine. And at that time, we looked around Abuja and the environs. We could not get desferoxamine. One of the team members contacted Lagos. We got desferoxamine and brought it. But fortunately, at the time it arrived, the patient was already getting better. The doctors felt there was no need for it anymore. These are my references, and thank you for listening.
Wow, I want to thank you so much, Master Zainab. That was a very, very interesting presentation. Thank you so much. Thank you. At this point, I want to recognize our TSM president here, Professor Cyril Gustavo. Sir, we recognize your presence here.
Thank you very much. Thank you.
Okay, sir. You're welcome. We also want to recognize our CPAN National Chairman, Dr. Joseph Madu. You are welcome. And also Dr. Solomon Wafu, our CPAN National Education Committee Chairman. You are welcome, sir. Welcome you. We also want to welcome I also want to welcome Pharmacist Adekunle Somiti, representing CPAN Diaspora.
Thank you very much.
You're welcome, sir. We are also welcoming everyone that is attending this presentation for the first time. Want to welcome you all, and then want to urge you that you should also that you should be attending these presentations every Friday, 9 p.m. Every Friday, we always have our CPAN presentation. At this point, we are going to be welcoming. We are just going to give a little, maybe like 3 minutes for those that have not sent in their state representative. Please send your name and also your state in the chat box so that we can have a roll call. We want to know the states that are very active that comes out of this presentation from time to time.
So let Pharmacist Galadima stop sharing a slide here.
Okay, thank you.
Okay, you can stop sharing your slides so that we can. Congratulations to you, Pharmacist Zainab, and also to FCP Abuja for this wonderful presentation. At this point, we welcome. Please, if you have any questions or any comments or any concerns, you can raise up your hand. Dr. Solomon Wafuru.
Thank you so much, my IPCC. Can I make any comment or appraiser?
Yes, you can.
Thank you so much. My president, PSN, here present. You're welcome, sir. National Chairman of SIPAN, you're welcome. I must congratulate Pharmacist Galadima. She did very well. It's not easy to face reputable and competent audience and be able to deliver this whole wealth of knowledge to the hearings and internalization of all the clinicians here present this night. But my own whatever, because I was not too fully in this lecture because of many other things I'm doing. But from where I catched up, let me be able to find out some things. One is, I don't know whether the Pharmacist Galadima said FBC 37%, or is it PCV?
PCV, sir.
Okay. Then secondly, you talked about inoculating or giving penicillin to somebody which might have contracted any infection from STD to a sickle cell patient or thereabout. My question is, if there is a blood culture and the microorganism turns to be gram-negative, will penicillin still work? The answer is no. I don't really, that's what I'm just trying to point out in that one. Then secondly is, I learned where they use the diazepam injection every 4 hours. Is it 4 hours or 6 hours, please? Like if diazepam is used every 4 hourly, my impact I wanted to make here as a pharmacologist is a one. Diazepam has a lot of 3 solid metabolites. And the least metabolite of diazepam has half-life of 60 hours. The highest metabolite of diazepam has 96 hours as half-life. If you dose diazepam in multiple frequencies, does it have any benefit when it's dosed once in a day? Because the metabolites are as potent as the prodrugs. So why dosing the metabolite in dosing diazepam in multiple frequencies when a single dose with the arrays and disposition of the metabolites in the system can achieve the same effect by a cumulative steady-state concentration in respect to multiple frequencies? So I just want to point that one out. And secondly, and thirdly, is you made mention of Coartem. You've done very well. I know this is your first time, and secondly, you just mission. People might not know what is inside coartem, and the dose coartem was used. Is it 140 or 280 milligram every 12 hours, or 8 hours start, and then start the next 8 hours or thereabout? Want to know the dose, because the weight of the child is 20 kg. Because you know, antemental lumefantrine is oil-based ACT. And this child is already suffering from dactylitis, which are complications from VOC. And if peradventure you have an oil-based drug accumulating so much in the cardiovascular system, the case will get worse and the child will get weaker without not recuperating faster. Then the next one is, you talked about reload immunity. It's a good one, but all of us know a major drug that will boost immunity of a sickle patient like Diascovite, Jobelin, and Neurozoin. I don't know why those ones were not suggested, but I will not, I say it, I am not going to talk anything or wait till what you presented, because you presented a very nice piece. Then the next is they say renal parenchyma disease, and we are unable to know which stage of the renal parenchyma disease, because the more advanced the stage, the worse it becomes. Is it stage 1? Is it stage 2? Is it stage 3? Because this has to talk about the renal system. Then the hepatomegaly. Is there any way there was an investigation to know, is it only malaria is responsible for hepatomegaly, when we know that worms, hematiasis, can equally be a cause of the hepatomegaly? Then is there any post-autogram USS to check whether the hepatomegaly is resolving? Because the point is that the person recuperated without to know whether there is a resolution at the end of the day. Then secondly, there is concomitant administration of folic. Sorry, this last one. There is concomitant administration of folic acid and progranil. Is it good when the mechanism of action of progranil is antifolate and they're supplying folate in the system? Thank you and God bless you. It's a wonderful one.
Thank you very much. Can she respond to this, to your questions?
Yes, she can.
Zainab, please, can you respond to all these questions?
Yes, I'll try. Thank you very much, sir. Actually, you said a lot, but I think I just got few. So in case I don't answer some of the questions, maybe you will like remind me again. The first one, you made mention of use of penicillin, right?
Yes.
Okay. What I said was that based on the guideline, penicillin is used prophylactically once a child is being diagnosed to have SCD, sickle cell disease, in order to prevent pneumococcal infection. That's based on the guideline.
Okay.
I don't know if you're okay with that response. Then
No
secondly,
problem.
Then secondly, the coartem was 2120. And
okay, good.
So it was given just 3 BD, 2123 BD.
Okay.
Then I think then you made mention of the complication, the kidney, the hepatomegaly. Actually, the primary cause of all of this was the iron overload, iron supplementation. The child was on iron for over a year. The child was actually coming to UAT at Gogolada, but at a point stopped coming and was now being managed in the rural area, and they were not educated enough. So it was the iron overload that caused all of that. So the hypertension was secondary to the kidney because, as I mentioned, that once there's iron overload, there's end organ damage. So those were the things that were manifesting. Unfortunately, everything resolved. Which other questions did you ask? I don't know if I answered.
Okay, no problem. I was mentioned of diazepam that has multiple metabolites using in multiple frequencies.
I think you were making like a comment. I felt it wasn't a question, it was a comment. So
it's not a question. I'm just trying to appraise.
Educate.
Yes, it's not. Yes. And secondly, the Diascovite that's supposed to be used that wasn't used. The Diascovite. Diascovite.
Okay. In UATH, because we have there's this professor Agumadu. She has her own cohort and she has her drugs that she uses to manage and is yielding result. For the past 5 years now, she's been doing that, and reload is one of the things she uses and is yielding result. As I tell you, this patient OS is now in SS2 and he's doing well, and he's been coming for his reload.
I want you to try. I want you to suggest Diascovite to the professor. Diascovite.
Okay, sir.
Suggest Diascovite. You will be amazed in the result you are going to get.
Okay, sir. Thank you.
Thank you so much.
Thank you so much, Dr. Solomon and then Pharmacist Zainab.
Thank you, dear.
At this point, let's take Dr. Joseph Madu. Your hand is up. Please, can you unmute yourself and talk?
All right. Good evening, Madam Moderator. Please, am I audible before I continue to speak?
Yes, sir.
Yes, you are.
All right. Let me still use this opportunity to recognize the PSM president. We know SIPAN is a new body, but he is the first president of PSN to be always attending SIPAN meetings. I also want to encourage everyone tonight. I can see that the attendance is about 81 for now, and I'm very happy that everyone in this meeting tonight is a SIPAN member, because you have to use your, hello, yes, can you hear me? Sorry.
Go ahead, sir.
Yes, so I'm very happy, as I said, everyone in this meeting tonight is a clinical pharmacist, because you have to use SIPAN registration number to log in. So we are talking to ourselves, and I'm very happy doing that. I want to encourage all of us to ensure that as we encourage other members from our states, even after now, we shall be having more persons in this. We have at least 700 registered SIPAN members in Nigeria, but this number is still very below what we can get, and it is always better participating in the meetings than probably going to watch the video after now. Most importantly, I know that we have all learned a lot this night. This is a very beautiful presentation to me, and I want to congratulate SIPAN MPC and the presenter most importantly. But then I have a comment to make to, or an appeal or a comment to make on the presentation. As I earlier said, that we are all talking to ourselves, we are all clinical pharmacists, we all logged in with our SIPAN numbers. So we are there are no foreigners among us tonight. I want us to remember that what is currently happening in the medical profession or healthcare system of Nigeria, apart from the knowledge aspect, there is also the political aspect. I observed that the presenter a lot of times used the word, we spoke to the doctors, we suggested to the doctors, she repeated it several times. And I want to say that last year or in year 2020, there was this bill in the National Assembly where the physicians or NMA are saying that they alone should be addressed as doctors. And we have kept on telling our colleagues, because we know there are several types of doctors in healthcare: pharma doctors, dental doctors, optometry doctors, and some of other ones. And we know we resisted. Even SIPAN made an input that no, the title doctor does not belong to a particular healthcare professional. So if we continue to address somebody as Zainab today, wherever we are, we say Zainab, even when we have all that Zainabs in our midst, then tomorrow we come out to fight that you are not the only Zainab in our midst, when we are always referring to you as Zainab, and others will say pharmacists and other things. That will not be right. So let us always remember the political component of this struggle, so that we always follow the SIPAN standard operating procedures, the guidelines, and the pieces of advice, that we should always use the word physician. Please, is the most appropriate. And permit me to also use this opportunity. I know that we shall do something in terms of SIPAN members. There is a book written by Professor Agua, and it's named, it's called The Making of Clinical Pharmacy in Nigeria. I want to use this opportunity to tell all SIPAN members to try and get that book and read it too. And Zainab, thank you very much. I did my project on the management of sickle cell anemia in selected hospitals. I know you have done so well. Congratulations. Congratulations to FCT SIPAN too. Thank you very much for the opportunity, Madam Moderator. Thanks.
Thank you very much, sir. Really appreciate you. Let's call on Dr. Raymond Okechukwu. Let's have your comments. Unmute yourself, sir, and talk.
Okay, hello.
Hello.
Yeah, please, can I be heard?
Yes, you can.
Okay, I want to join my voices with those that have spoken earlier to commend this presenter. It was actually exceptional. I also stand on the existing recognitions. So the presenter, please, I cast my mind on what you said about the use of labetalol. I address this issue. I don't know, maybe because of the area where I stay, labetalol is not commonly available. I don't know about the FCT or the hospital where you work. It's not enough to just suggest the lab. Is it available for the patient? So we don't have issue of access and cost. And talking about prevention of, malaria in this patient, you only mentioned the use of Progranil, and well, later you talked about hygiene. Are things like insecticide-treated nets not useful for this patient? And other things that will make sure the patient avoids mosquito bites, because these are the issues that actually predispose them, all of us, to malaria. I will keep it short at this point and say congrats once again for this wonderful presentation.
Thank you very much, sir. Pharmacist Zena, please, can you respond?
Okay, thank you very much, sir. Yeah, actually, labetalol is readily available here. In fact, we have enough of it. That was why we suggested that. Then regarding your comment, is noted. Thank you very much.
Okay, thank you very much, too. Let's call on Pharmacist Adekunle Tometi.
Thank you very much. Thank you very much for the, I have. Thank you very much for the opportunity. Sorry, I'm here compounding at the moment, but
oh, wow.
I thank you for the presentation. It was really beautiful. One thing I wanted to say in the light of the last speaker is therapeutics is very important in management of most diseases. As with sickle cell, if we dial our minds back some 30, 40 years ago, it was such a big opportunity for medicine. We didn't have enough therapeutics. And one of the things that has helped us a lot since those days, even going back in the 60s, is the advent of vaccines. And with vaccines, we've been able to stall and keep at bay the sickle cell patients' propensity to always pick up infections. And normally, for them to even get so sick to come into the hospital is often predisposed by them picking up a pneumococcal infection or picking up a meningitis infection. Accordingly, my contribution here today is we as clinicians, we as pharmacists should always be out in front of this, promoting the importance that all sickle cell patients that we have are completely vaccinated. So their pneumococcal vaccination, we should assure anytime they come into the hospital that they're up to date, they've taken their PCV13, they've taken all the doses that they need to take. We should also make sure that their meningitis vaccinations are all up to date. If we can do that, we can drastically reduce how much crisis these people have and how often they have to come to the hospital, thereby reducing the cost of healthcare for them and improving our outcomes with these patients. Thank you very much. I appreciate you.
Thank you very much, sir. Thank you. Thank you very much. Wonderful contribution. Thank you, sir. We recognize you, sir, Professor Cyril Usifo, our PSM president. Sir, please, you can unmute yourself and talk.
I want to appreciate all past speakers and those who have participated. We will need to encourage ourselves, because one thing that is certain, if you are a good teacher, you must also be a good student. You must be willing to cross-fertilize ideas with other people. I'm so happy that Dr. Tometi is part of us. Next week, he will be invested as a new fellow with us. And I also want to appreciate Dr. Madu for what he has also contributed. We need to be proactive and we need to be sure of whatever we are doing. And nobody should look down on you. I just want to quickly make comments and ask colleagues to feel free. And possibly we can raise up a kind of a 2 or 3 man committee to look at some issues and probably get that across to me. Mr. President, our dear Buhari created a health reform sector reform committee, and the Vice President inaugurated us last week. But one thing was certain, I came out strongly to say that it was unfair to allow only one pharmacist where you have so many medical doctors.
Wow.
By the time we break up into thematic areas, we're going to talk more about that. So I will want Sipan to do something and then send a position paper to me as the case would be, so as to be able to follow that up. And coming back to the topic of the day, I want to appreciate my sister for what she has presented. I also want to say that as pharmacists, we must have that sympathetic heart when caring for sickle cell patients. If you've ever seen somebody with an episode, you really need to have that loving heart. In that way, you can care for the patient very well, even as we talk about the drug, therapy, and the rest of them. I pray that anytime Sipan is having a program, I would endeavor to be around, because not only just contribute, I also want to learn, even though I'm a professor for almost 20 years. God bless you.
God bless you, sir. Thank you very much, sir. Really appreciate your comments. And all you said concerning Sipan and your proposition, it has been noted down. So we are going to discuss it and then let you know. Dr. Madu is here too. Dr. Madu, please, can you respond to that? Are you there?
Yes. Am I audible?
Can you respond? Yes, you are. You are.
What Prof just said now gladdens my heart so much, because I have seen certain things that happen in pharmacy. Prof, sorry, permit me to say this. I know we are all talking to ourselves. We have all strictly been screened, and we are all clinical pharmacists in this meeting tonight. I have seen certain things that have happened before now. And by the time I looked at it, for instance, the National Health Policy in 2018, National Health Policy of 2018, I discovered that in that document, a CHU or a nurse, in the absence of a physician, can prescribe even controlled drugs. And nothing was made mention about a pharmacist in the absence of a physician or nurse, in the absence of a physician. The pharmacist can only dispense it, while these people can prescribe. And by the time I looked at that document, sorry to say, this is not to indict any person, but I discovered that some pharmacists were part of the committee that put up that policy, that document, National Health Policy of 2018. I don't know if
you're right.
Has been reviewed. Yes, sir. So what I'm trying to say, what you have done right now, sir, is just the best, because no one knows it all. And you know what has been happening in Sipan, especially with the pool of experts. So we can assure you, the Health Reform Committee, so there's another group, so permit me to say this. I think I will also add you to that group. We call it Coalition for Health in Nigeria. And we actually somehow in Sipan started it. And I know the physicians there have been telling me that we must make something, a submission to the current Health Reform Committee led by the Vice President. So,
Yes.
But I'm very happy now that at least PSN is telling us something. And you remember that 10 heads are always better than 9. So
of
by
course.
the time we put our heads together, I believe we shall give you something. Even if you're a one-man person in that committee, it will be very very tough for anybody to just just belittle your contributions by the grace of God. Thank you for telling us to do this. God bless you.
Yeah, I'll be delighted because even early this morning, they started getting some more, they called urgently to get some more information from me about my background. Maybe they want to run some background check, but I'm ready to take the battle to them because when the thematic area comes, like I suggested, and I'm going to hold on to that, when the thematic areas come, we are going to ask that they should allow more pharmacists to be on board. So don't be surprised if I call all of you, if your names are mentioned. I hope I will get support. I should get support because one of my classmates who's a retired CMP is also on board.
All right, sir. God bless you.
Bless you too.
Yes.
All right, sir. Thank you so much. Thank you so much. We are calling on Dr. Peter Afonsos. Please, can you unmute yourself and just go ahead?
Okay, good evening.
Good evening, welcome.
Can you hear me?
Yes, we can. Yes, we can hear you.
Okay,
go
fine.
ahead.
Wonderful presentation, Pharmacist Zainab Galadima. With respect to drug therapy for your sickle cell patients, I attended a conference sometime in November last year, a cardiovascular conference, so to speak, and some AC inhibitors were being repurposed for sickle cell anemia. I think it should be enalapril or so. And I think the dose was specified for sickle cell patients. So I don't know if in the course of your work, you have actually done one or two research in that area, and if you probably have or know the rationale behind why we may use some angiotensin converting enzyme inhibitors, to manage sickle cell patients. I saw you actually use the medications. Labetalol was there, a beta blocker, and you talked about, but just for you to look at, based on recent findings, if it actually has a place in the managing of sickle cell patients in its own right. So I think it's a question I'm just asking if you have some extra light to make in that order, and if it's something you could look at because it's a new trend. Thank you.
Thank you very much.
Yeah, you can respond, ma.
Okay,
yes,
thank you
can.
very much, sir. Well, actually, I'm just hearing this for the first time, and I didn't come across any research regarding that. But the reason why enalapril was used here is just because of the renal protection. Since the child was already having some compromise with the kidney and is going to be placed on labetalol. So that was why we suggested the enalapril. I'm going to look it up. Thank you very much, sir.
Thank
so
you
I don't know if I answered.
Thank you.
Partially answered the question. Yeah, thank you.
Yeah, you did,
yes.
you did, but there is a dose related to the management of sickle cell patients that has evolved, so you could look that and probably add it up. Probably when if you need to make interventions, you could be giving some new information to the medical team that they would appreciate.
Okay, thank you very much, sir. Noted.
Thank you very much, sir. Super National, I'm seeing you, but please, can you just wait a while? You may even give us the vote of thanks. I want to recognize the DPS Osun State HMB Pharmacist Fashipe. Are you there, please? You are highly recognized. Do you have anything to say? Concerns, comments? The DPS Osun State HMB. Okay. All right then. Let's Pharmacist Chido Okoye. You are recognized, please. You can unmute yourself.
Okay, good evening, everybody.
Good evening, sir.
Good evening. You're welcome.
This is Chido Koyan. Okay, so what I want to say is that, well, I joined late. I'm sorry for that due to other engagements. But what I want to say is that members of SIPAN, both the full and associates, full members and associates, what we discuss in these meetings are mostly about orthodox drugs.
Okay, yeah.
Other thing is discussed. But you understand that the WHO, with the World Health Organization, now also
Service is bad from your hands, sir. Pharmacist.
is this like the traditional complementary rates?
Service is bad from his hand, but it would have been very interesting because I know that he is into trado medical. So it would have shed more light on it. Maybe there are some other alternatives you can
I am
give.
back. Can I
Sir,
conclude?
service-
I'm back.
Okay, fine. Go ahead, sir.
Can I quickly conclude?
Okay, sir.
Okay, so like I said, there are bills the federal government is taking it to incorporate these alternative systems into our healthcare delivery system. So I don't want us to be left out. I don't want pharmacists to be left out. We are the custodians of drugs, both orthodox and complementary or alternative. So the earlier we start also looking in that direction, the better for us, so that we will not end up with the kind of situation we have with the veterinary medical doctors, whereby they prescribe and they dispense at the same time. So that is just my plea. So going forward, or maybe in the future, I want a situation where, for example, the topic for today, after presenting the aspect of the orthodox interventions using orthodox treatment, we can also choose one area in either traditional, complementary, or an alternative system, and also present on that. Like I know that homeopathy also has very good treatment modules for sickle cell anemia. Even very good ones, very excellent ones. So that's my own contribution. Thank you very much.
Thank you very much.
Sir, that's a very interesting contribution. Are you promising us that you are going to be giving us such alternative in each of our presentation when it comes to disease conditions, like this one now that we just had? You have this alternative. Yeah.
Yes, if I joined earlier,
yeah,
maybe I would have listened to full presentation, and then I'll also make contributions on how sickle cell anemia can be managed through homeopathic medicine. There are excellent remedies for managing sickle cell anemia. Thank you.
Okay, that's good. We are going to contact you. Some of us have even joined your WhatsApp group. We are trying to learn. We want to find out some of the, some of the steps, some of the processes. I don't know whether it involves the. I know it's a specialty on its own, but maybe with time,
Yes.
we may need to invite you again. We may need to invite you again. We have invited you before. Sometime, I think in 2020. Yes, you had a presentation with us and you tried to explain to us.
Yeah.
Yes. Some of us would like to know how we can acquire and what it takes, you know, training and retraining. Some of us would like to know. So with time, we are going to contact you, sir. Thank you very much. Thank God that Dr. Solomon Wafuru is here. The education chairman is here. So he's also taking note of everything. Thank you so much. Yeah, so at this point,
all right, thank you.
Yes, thank you. And we have a few minutes. Let's listen to Pharmacist Jude Owodi. Please briefly, can you just unmute yourself and tell us what you give us your own contribution?
Good evening, everybody. Please, am I audible?
Well, you are almost.
That was
close to your mic, sir.
Hello?
Go ahead, sir.
It was a wonderful, very wonderful presentation this evening. I would like to just make a little comment, just in relation to what the last speaker just talked about. I don't know what of regenerative medicine in the treatment of sickle cell anemia. You know, because why I'm saying this is during the presentation, the speaker made mention of the fact that, which we all know, that sickle cell disease can only be managed. But the only way you can treat it effectively is when you do a bone marrow transplant. And bone marrow transplant has to do with a kind of surgery where the bone marrow will be transplanted with a donor cell that is not sickled. And it's a very costly project. So I don't know, are we looking at alternatives? Because there are other methods that have proved very effective, especially with this recent discovery of alternative stem cells. For instance, double stem cells. You know, I don't know whether we are conversant with it. This is a product that was discovered by Global Biochemistry about 9 years ago. And since then, people have been using it in the treatment of so many ailments. And in the treatment of sickle cell disease, it has proven very effective. And this regenerative medicine is just a kind of healing from within. In other words, the cells are stimulated to regenerate new cells. And in some cases where it has been used in the treatment of sickle cell anemia, it has led to the change of the genotype. Children that were not going to school, that had challenges because of crisis, are now stabilized and they can go to school. So it's an area I would like us to look into, which is really generating very positive results. So that's the little contribution I want to make this evening.
Thank you very much, sir. Thank you. Just like we've told the pharmacist Chido Okoye, with time we are going to contact you. We'd like to know more. Some of us have joined the WhatsApp group, hoping to even learn more. So thank you very much. At this point, we'll call on Dr. Ibrahim Bello. Please give us your vote of thanks and round up for us, and also with a closing prayer. Let's have your comments. The roll call, I'm going to just paste it. I'm going to type it and then send it to all the WhatsApp group, all the pre-registered SIPAN WhatsApp group. Those that attended, the representative from the various states, because we will not have time now to start telling you FCT this number, this number. So Dr. Bello, please can you give us a vote of thanks and round up for us?
Okay, before the first of, I have a question for Pharmacist Zena.
Okay, sir. Okay.
Only one. Yes. One of the assessments for the patient is renal impairment. And this patient is on a lot of medications that could be nephrotoxic. Did you consider dosage adjustment in this case at all? That's the only comment I have for you.
Well, okay, you know, the reason why we had that renal impairment was because of the iron overload. It was secondary to something. So once we now handle that, everything resolved.
Okay. That is taken. Thank you so much for that. So, at this point, we want to thank you all for joining us tonight. Most especially, we want to thank the PSN president, Professor Siri Isivo, and Dr. Tomiti from the state. And all participants tonight, we thank you, we appreciate you. And we say next week is going to be another very interesting time. We especially thank CPAN FCT for producing this very great, educative, and impactful presentation. Thank you all, and good night, everybody. Thank you.
Thank you very much. Thank you.
Good night. See you next week.
Good
God's
night.
grace. Yeah.
Thank you. Good night.
Sweet dreams.
Right. Good night. Thank you.
Good night. Good night, everyone.
Good night.